All right, so a home stretch here, and I'm going to be talking to you about cardiac arrest, a little bit about ICU management of patients who have survived cardiac arrest, and a lot more about monitoring and prognostication in these patients. These are definitely some of the sickest and most challenging patients that we care for in the neuro ICU. And it can be rewarding in some cases, but a lot of times these patients have poor outcomes, and it can be very difficult on staff and very time consuming and emotionally draining to care for these patients and their families as they struggle in making decisions about where to go and what the chances are of these patients recovering. And a lot of what we do in neurocritical care is really guiding those decisions and trying to use the best data that we can to determine if patients are going to recover, what sort of recovery to expect, and then guide families through that process. So I think this is a really important part of what we do in neurocritical care. And so I'm honored to come and talk to you about this topic. I don't have any disclosures except to say I spent 4 years at Johns Hopkins inducing cardiac arrest in rats and then resuscitating them and monitoring recovery of the brain during that process. So I have murdered many rats in an endeavor to study this disease process. Okay, this is a very frequent condition that we treat. And it's even if as a neurointensivist, we don't directly care for these patients in our ICU, not all neuro ICUs do that. But even if we're not directly caring for these patients, we're very often consulted for prognostic purposes or to assist with management of these patients. And almost all patients who survive a cardiac arrest are initially comatose. And so the nature of the consult is generally, what are the chances that this person is going to recover from coma beyond just a vegetative state? What is the chances of the patient recovering? And the data is pretty grim. If you look at all comers who have survived a cardiac arrest, fewer than 10% of them are discharged from the hospital neurologically intact. But if you look at case series and clinical trials that have been completed, the data is a lot better in patients who survived to be admitted to the hospital and were managed in an intensive care unit with full care for full supportive measures. You can see published data as high as 60% of patients eventually making a good neurological recovery at 6 months. And so the data can be grim overall, but patients who make it to the ICU and are aggressively managed, as many as half of those patients can ultimately have some good neurological outcome. Cardiac arrest is not stroke. It's just a different animal altogether. Stroke is really, in most cases, permanent occlusion of a blood vessel and ischemic injury to part of the brain as a result of that permanent occlusion. Cardiac arrest is a different model of ischemia. It's a no-flow, reflow model, meaning there's a period of time when there is no brain perfusion and brain tissue oxygen effectively drops to zero. And then when the heart is resuscitated and the blood pressure is restored, there's reperfusion of the brain. And because of that disease process, the injury to the brain is very different from stroke. Rather than seeing wedges of infarcted tissue the way you do in stroke, you more typically just see bland necrosis of neurons. And these neurons just drop out, and the injury is on a cellular basis. And there's selective vulnerability of different parts of the brain. The large, very metabolically active projection class neurons in the deep cortical layers and in the hippocampus are selectively vulnerable to this disease process. And why are those important? They're important because those are the underpinnings of the network functions of the brain. Those are the neurons that control our cognitive processes, our memory, and really are the underpinning of consciousness. The activity within cortical networks and thalamocortical networks is really what is the underpinning of consciousness and cognitive function. And so patients who have survived cardiac arrest have a constellation of problems that gets referred to as the post-cardiac arrest syndrome, and results in cognitive dysfunction and very selectively is involved in encoding memory, and the hippocampal processes involved in memory encoding. And even patients who have survived well or have recovered well after cardiac arrest very commonly have cognitive dysfunction and very, very commonly have difficulty encoding new memories. There's also a movement disorder that's very characteristic of the post-cardiac arrest syndrome, which is an action-induced myoclonus called Lance-Adams syndrome. And together, those make up the post-cardiac arrest syndrome. I told you I spent 4 years inducing cardiac arrest in rats, and I spent 4 years also kind of proving to ourselves that cooling the body temperature of the rat after cardiac arrest improves outcomes. We did electrophysiological monitoring of the brain and looked at network activity of the brain during rats who are normothermic and rats that were cooled. And I have numerous publications showing how effective this is in rats. So Magdi and I can sort of commiserate about the translation of that as well. And I'm not going to spend a lot of time talking about what the ideal target temperature should be after cardiac arrest. There's debates sort of raging about that now. But I will show you that the TTM study that was published a few years ago that effectively found that patients who were managed at 2 different target temperatures, 33 degrees versus 36 degrees, had similar outcomes, had similar mortality, and had similar cognitive recovery or functional recovery at 6 months. Patients who are managed at both of these temperatures. And so the current guidelines really reflect the options of different target temperatures, and the guidelines suggest a range of target temperatures between 32 and 36 degrees. The TTM2 study is ongoing, and it's at about 500 patients enrolled so far, and that study will look at 33 degrees versus 37.7 degrees, which really is not hypothermia. It's a comparison of hypothermia versus fever control. And so it'll be really, really interesting to see what the result of that trial is when it comes out, and probably in about 2 years, we'll know the results of that. The other clinical trial on post-cardiac arrest management that I'll draw your attention to is an early goal-directed therapy for cardiac arrest patients. And this was just published about a month ago. And the study looked at early goal-directed therapy, very similar to what was done in sepsis. Maintaining a mean arterial pressure greater than 85 and an SVO2 of 65 to 75% versus standard therapy, which is a mean arterial pressure greater than 65. That's the standard therapy that's in the guidelines. And they randomized, it's a relatively small trial, but it was a well-designed randomized controlled trial, randomized 112 patients. And they looked at functional outcomes. They also looked at an MRI marker of ischemic injury called the ADC score. I'm going to show you that in a little bit. And then they also measured cerebral oximetry in this study. And what they found is that patients in the early goal-directed therapy versus standard therapy, they did maintain a higher mean arterial pressure. In the early goal-directed therapy group, they used more vasopressors here. And they did actually increase the cerebral oximetry of patients as a result of that. And they did also use TCD to measure MCA blood flow to the brain. And they did augment blood flow to the brain when they elevated the blood pressure and maintained a SVO2. However, outcomes were not affected by that, surprisingly. And the outcome that's used is a CPC, which is like a Glasgow outcome score. Basically, lower scores mean less brain injury, were the same between the two groups. And then the ADC score using the MRI marker of ischemic cortical injury was the same in the two groups. Okay, moving on to neuromonitoring and prognostication. The real crux of prognostication is multimodality, really. And it depends on the clinical findings based on the neurological examination and also biomarkers. EEG and SSEP are commonly used electrophysiologic tests. And I would say a couple of years ago, I wouldn't have put imaging studies on this, but imaging studies have really become part of how we prognosticate in this disease in a way they were not in the recent past. The American Academy of Neurology released a guideline back in 2006, which has been the standard for how we prognosticate, when we prognosticate, what tests are done, and what those prognostic markers mean in this population. And what I'll say about this algorithm is that it's outdated. and really is in need of update at this point. And at the end of the talk, I'll show you the European guidelines, which I think are more contemporary. But I will show you this because it is the current guideline from the American Academy of Neurology. And when we talk about prognosis in cardiac arrest, almost all prognostic studies that are done are negative prognostic studies, meaning how do we predict who will not recover? You know, what are predictors of who will not recover? Very little research has been done to look at early prognostic markers of people who will recover, of good prognosis. So this is no different. The AAN guideline really looks at tests for people who will not recover after cardiac arrest. And it's based on absence of brainstem reflexes, myoclonic status epilepticus, and then absence of cortical transmission in electrophysiologic tests using SSEP, a serum biomarker called neuron-specific enolase, and then at 3 days, absence of cranial nerve reflexes and absence of motor movements that are better than posturing. So either no movement or extensor posturing. Okay. So the clinical examination is part of every prognostic test in cardiac arrest survivors. And the elements of the clinical exam that are most important are, of course, arousal and consciousness, cranial nerve reflexes, including pupillary reflexes and corneal reflexes, looking for motor response, either extensor posturing or no movement, examining for post-anoxic myoclonus, and looking for epileptic seizures. Part of the problem, and one of the reasons I say that the AAN guideline is outdated, is that it looks at motor responses at 72 hours. And one of the concerns in the hypothermia era, whether that be 33 degrees or 36 degrees, is that medications are needed to, as Stefan mentioned, suppress shivering. And sedative medications are needed to suppress shivering. And that can really mask the motor exam, and there can be delayed metabolism of those sedative medications. And so there's a lot of concern that you would have a falsely pessimistic prognosis based on the motor response alone at 72 hours in patients who are treated with hypothermia. And that is really borne out by the literature. This is, you know, in addition to the TTM study showing that 36 degrees had equivalent outcomes to 33 degrees, there have been about a dozen subsequent publications looking at the effects of prognostic testing in the patients who are enrolled in this study. And looking to see if hypothermia altered the prognostic value of those tests. And so the motor score is the one that really shook out here. What I have highlighted over here is the false positive rate. And so the GCS motor score less than or equal to 2, that's extensor posturing or no movement with stimulation, has a false positive rate as high as 40% in patients, really in both groups of hypothermia managed patients. Okay, post-anoxic myoclonus is something anybody who's taken care of post-cardiac arrest patients, I think, has probably seen this. It's a very dramatic presentation. Patients have trunk predominant stimulus-induced myoclonic jerks, really of the whole body. They can be very severe and can actually interfere with the ability to ventilate the patient. They can be so severe. And, you know, for families really struggling with decision-making of their loved one who's in a coma, who survived this cardiac arrest, these can be very, very disturbing to see this, and for caregivers as well. They're not considered seizures per se, although I think with what Stefan showed with depth electrodes in patients who have burst suppression EEG, he might argue with me on that point. I wonder, I don't wonder. I'm very, you know, I'm pretty convinced that if you put a depth electrode in these patients, you would see seizure activity during these events, but we don't call them seizures. In a lot of ways, it's inconvenient to call them seizures, because if you call them seizures, then you have to treat them, and they're very, very hard to treat. They're very treatment refractory, and you're gonna end up with a lot of barbiturates in these patients. And if you give barbiturates to these patients, then you're not gonna know if the patient's gonna wake up for like a week. And so I think a lot of it is a willful sort of, you know, if you can't stand the answer, don't ask the question, right? So, but they're not considered quote unquote seizures per se. They are very prognostically important. And that is something that has persisted in the literature, which is that a tick of myoclonus here and there during the first 24 hours really has no prognostic value in these patients. So if you see a little myoclonus during the first day, that's not this. Okay, this is persistent myoclonic status, meaning frequent stimulus-induced, very stereotyped myoclonic jerks that persist for greater than 24 hours. That has remained very prognostically important in that it has very high specificity for poor outcomes in these patients. Okay, a word about neuron-specific enolase. I don't personally test this as a prognostic marker in cardiac arrest survivors, in large part because in Hawaii it's a send-out test and it takes a week to come back, and that has no value to me. So I don't have a lot of personal experience with NSE. It did make it into the AAN guidelines at a cut point of 33, meaning if it's higher than 33, patients will not recover. But there was a lot of controversy subsequently, especially in patients who are managed with hypothermia, that there could be false positives at that cut point. So I've seen other publications suggest 50. I've seen others suggest 90 as a more accurate cut point. And it's also time dependent. So if you test it on day one, basically NSE is released into the serum because there's a lack of oxygen to the brain or a lack of perfusion to the brain, and then restoration of perfusion. And so there's a delayed rise, and if you test it during the first day, you may not actually catch the rise of it. And so day 2 or 3 tends to be the peak in patients, and it's better tested on those days. Okay, this is also from the TTM study, basically looking at this question of, does hypothermia in and of itself increase NSE, as some publications had shown? And at least in this study population, it did not. And NSE continued to maintain its prognostic value in hypothermia managed patients. Okay, some words about electrophysiological testing for prognostic purposes in these patients. The 2 main tests that we do for prognosis after cardiac arrest are EEG and somatosensory evoked potentials. And we test those because they do what I did in the lab with rats, which is measure the network function of the brain. The cortical thalamic loops, or the thalamocortical projection of electrical information into the brain, is measured by EEG in part, and mostly by somatosensory evoked potentials. And the negative patterns, or the malignant patterns of EEG that we see in patients who have survived a cardiac arrest, are low entropy states. Whereas the brain, typically when there's network function of the brain, the electrical activity that we see has high entropy. It's variable, it's reactive. Like if you stimulate the patient, there's a change in the EEG that you can measure. Whereas when there's an injury to the brain and network activity of the brain is lost, then the brain becomes much more rhythmic or periodic and less entropic and not reactive to external stimulation. So the classic kind of malignant patterns that you see that have poor prognostic information are electrographic seizures, what's called burst suppression, which is alternating periods of EEG suppression and abnormal activity. Non-reactive EEG patterns, EEG that does not change with external stimulation. Here's an example of burst suppression. The one on the left is actually anesthetic burst suppression. The one on the right is actually burst suppression induced by anoxia. They can look similar, but these are alternating periods of EEG suppression and then bursts of EEG activity. Electrographic seizures also have a poor prognosis, but the prognostic value of them really depends on what they emerge from. And this is another kind of, another sort of danger point, which is that not all electrographic seizures in patients who have survived a cardiac arrest portend the same poor prognosis. It really depends on what that electrographic seizure emerged from. And this is where continuous EEG is really, really important in patients who have been resuscitated from cardiac arrest. What is the initial rhythm that you see? What does that rhythm evolve into? And if there are electrographic seizures, what did those seizures evolve from? Did they evolve from burst suppression, and then the bursts become continuous and then they become seizures? Or did the patient go into a reactive EEG first and then go into seizures after that point? And you can't really get that information in retrospect if you just put an EEG on somebody for prognostic purposes on day 3 and you see that they're in status, right? So you don't really have the information of what that status emerged from at that point. Some examples of this is actually from my friend Peter Kaplan at Hopkins, and we've published quite a bit on electrophysiology for prognosis in cardiac arrest patients. And Peter published a series of 6 patients who awoke and had good neurological outcome after cardiac arrest despite having status epilepticus. But it really kind of drives home this point of what did that emerge, who is that patient, what is the context of that electrographic status. And you know, the things that I highlight here are that all of these patients had preserved brainstem reflexes. All of these patients actually had EEG reactivity. Not only was the EEG continuous and not burst suppression, the EEG was reactive to external stimuli before the status epilepticus developed. So this is a different animal, and all of these patients had cortical responses on the evoked potentials as well. Okay, what are the issues with EEG? There's, you know, certainly EEG is affected by sedation, right? So if you need sedation to suppress shivering, the EEG can be greatly impacted by that, and the prognostic value, especially the reactivity of it, right, or the variability of EEG, is really suppressed by sedation. And so you have to be careful with using EEG for prognostic purposes in patients who have been recently sedated to suppress shivering. There's also a question about timing, the timing of the prognostic value of EEG with respect to the cardiac arrest. And there's a lot of borderline patterns, as you know, anybody who's done ICU EEG knows that there are a lot of different patterns that are on the ictal, interictal spectrum, and it's not clear what their prognostic value is. This is not a human, this is a rat, actually. This is a 2-channel EEG in a rat. And it shows something that I want to highlight, which is that this is a baseline EEG in the rat. This is the EEG of the rat during cardiac arrest. And then after resuscitation, the first thing that you see is a return of burst suppression. So burst suppression beginning here, and then the bursts become more frequent, and then the bursts merge into a continuous EEG, and then the EEG becomes reactive. And if you put EEG on a patient who's resuscitated from a cardiac arrest early enough, you will see the same pattern. Every single patient who's been resuscitated after cardiac arrest goes from complete EEG suppression to burst suppression, more frequent bursts, continuous EEG, then variable reactive EEG. And it's a question of when you put the EEG on that patient and how quickly the patient gets out of burst suppression into a continuous rhythm. That has the most importance. So if you see burst suppression EEG on day 1, that doesn't mean the patient is not going to recover. If you see burst suppression day 3 or a week into it, that's a different story. So examples of this in humans, not in rats, showing a patient going from burst suppression during the first day to a continuous EEG the following day. Somatosensory evoked potentials are an electrophysiological test where the median nerve is stimulated in the arm, and then conduction of that electrical stimulation is monitored through the neuraxis, through the peripheral nerve, through the brachial plexus, the cervical spinal cord, the brainstem, the thalamus, and the cortex. So this is a typical normal median nerve SSEP. The N8, what's called N18 by convention, this is monitored on the scalp, and this is a thalamic potential, and then a cortical potential in the primary sensory cortex. These are early latency cortical potentials. N35 is a middle latency potential, and then there are longer potentials as far out as 70 milliseconds after the stimulus. And these early potentials reflect thalamic, primary sensory cortex, and then intracortical network processing of that sensory stimulus. Examples in cardiac arrest survivors that I've seen, this is normal. This is how it should look. You see a robust N18 and N20 on the cortical leads, reflective of intact thalamic to cortical projection of the stimulus. This is what you don't want to see, which is the complete absence. Everything's intact in the periphery here, peripheral nerve, cervical spine, but there's no cortical or thalamic projection of that stimulus. And when this is seen 24 to 72 hours after cardiac arrest, it's a very highly specific, poor prognostic sign that there's too much thalamic and cortical injury. There's no network activity in the sensory nervous system, and the patient is not going to wake up from the injury. Okay. A lot of times you get this, though, which is difficult to interpret. These are not normal, but also not absent. SSEP is less affected by sedation. These are done as part of intraoperative monitoring in patients who are under general anesthesia. So they're less impacted by sedation compared to EEG. Timing is an issue, though. And there were ongoing concerns that hypothermia might delay or suppress cortical transmission of SSEP. But again, data from the TTM study basically showed that the false positive rate of absent cortical EPs remains very, very low. And so even in hypothermia treated patients, EPs remain one of the most accurate and reliable negative prognostic markers. A few words about neuroimaging. There's actually some studies looking at plain CT as well, looking at loss of gray-white distinction in plain CT. But a lot of studies have come out in the last few years looking at different MRI techniques as a prognostic marker in these patients. And often, even in patients who have very poor neurological outcomes and are comatose, when you get an MRI, you see nothing because it's that bland kind of cellular level necrosis that I showed you. And so not seeing any cortical injury doesn't necessarily mean the patient is going to recover, but seeing cortical injury on MRI, there's emerging data showing that that does have prognostic accuracy as a negative predictor. And these are some examples looking at FLAIR, diffusion-weighted imaging, and absolute diffusion coefficient, or ADC. Some more examples of cortical injury. Some authors have tried to semi-quantitatively or ordinal, I guess, prognosis using a MRI score in patients with cardiac arrest, and have showed that patients with these two, either in combination of cortical injury and basal ganglia or cortical injury alone, has very high specificity for poor outcome, where patients are not going to recover after cardiac arrest. And then the Stanford group, and Stefan Mayer was actually a co-author on this as well, and Greg Albers as well, two speakers at this conference, has done a lot of work looking at quantitating the diffusion, the restricted diffusion, using ADC maps and quantifying the amount of ischemic injury to the brain. And so this dark signal that you see in the cortex on the ADC maps here, and quantifying how dark it is. And this is this is similar to what is done with the rapid ischemia view software. That uses a cut point of less than 620 as ischemia. This uses less than 650. But if greater than or equal to 10% of the brain has low diffusion in the cortex, that it has very high specificity for poor outcome in these patients. There's no perfect test. So there's no one single perfect test that tells you, okay, I can be 100% certain that this patient would not recover beyond a vegetative state based on one biomarker. And so there's a lot of interest now in taking this very large body of literature, prognosis and cardiac arrest, and combining it into multimodality prognostic markers using a combination of EEG, somatosensory evoked potentials, and the neurological examination. And that really has led to the 2015 guideline produced by the Europeans in the ESI, the European Society of Intensive Care Medicine, released this. And this is what I use when I prognosticate in patients who have survived cardiac arrest. I don't use the AAN guideline anymore. I use the ESICM guideline. And I don't know if, I hope you guys will have access to the slides, because the next two slides I took from the ESICM guideline and collated this in a way that I think makes the most sense, which is looking at the false positive rate for all the various prognostic tests at 24 hours and 72 hours, hypothermia or no hypothermia, and also the sensitivity of those tests. And I think that's the information that you really want to know, is how sensitive is this biomarker for poor outcome, and what is the false positive rate of this biomarker. And so I hope that you get access to the slides, and these next two slides are worth taking a look at if you do any prognostication in this patient population. This is the ESICM algorithm. And really what the guideline tells you in Europe is manage the patient aggressively for 2 days, get them through the hypothermia and rewarming period, and then on day 3, begin your prognostic testing. And it's kind of like the Chinese menu approach where it's like 2 out of 4. You have to have 2 out of 4 bad biomarkers, and then you can prognosticate with a very high degree of certainty and a low false positive rate. And so what they recommend is looking at brainstem reflexes at day 3 and absent N20s, which are the cortical responses on EP. If those negative prognostic markers are both absent, meaning the patient has reactive pupils and has corneal reflexes and has cortical N20s, then wait another 24 hours and then do the next step if the patient has not woken up or begun to wake up at that point. And then look for, did the patient have myoclonic status during the first 24 hours? That's where NSE comes in. That's where your EEG comes in and potentially your neuroimaging come in. And if the patient continues to remain indeterminate, meaning they have not woken up at what is now 3 to 5 days, but they lack these very specific biomarkers, then they fall into this indeterminate prognosis group, and it's reasonable to continue to manage those patients aggressively to see if they will subsequently wake up. There has been some research into favorable prognostic markers. Everything that I've showed you so far is actually negative prognostic markers, but how do we test to determine, hey, this patient is worth aggressive management? Because these are very sick patients. They often have balloon pumps. They need coronary angiograms. They need a lot of ICU monitoring. And so we don't just want to select out the patients who are not worth continuing that management. We really want to identify early on who has the high potential to recover and is worth this investment of all these resources, and also correctly messaging to the family as well. And so there has been a little bit of research looking at positive prognostic indicators, but certainly not as much as negative prognostic indicators. The easiest one is the patient wakes up, right? If the patient wakes up and becomes conscious, that obviously has a lot of good prognostic value. But the other good one is early EEG reactivity. And so here's an example from the literature showing that kind of what I showed you in rats, which is that it's not just, is there burst suppression? Yes, no. It's how did that EEG evolve during the very early period after cardiac arrest. So this patient up here who had a good outcome, 7 hours after the injury, it has burst suppression, but by 19 hours, it's all continuous. And by 70 hours, it's not just continuous, but reactive and highly variable, right? So the patient had burst suppression early on, but quickly moved out of that into a continuous EEG pattern that became reactive, whereas the patient in the bottom panel who had poor prognosis remained in burst suppression at 24 hours. And then EEG eventually became continuous and disorganized, but was not reactive and did not have high variability. And so these authors found that EEG that became continuous, that was no longer in burst suppression, but it was just continuous EEG activity by 12 hours, has a pretty good has very high specificity for good outcome. And this is just another reason to do early continuous EEG monitoring in these patients to determine not just are they in burst suppression, but how quickly do they emerge from burst suppression and what does that EEG evolve into? There's been some interest in looking at longer latency somatosensory evoked potentials beyond 35 milliseconds, a few small publications on that topic. Some authors, particularly in Europe, have looked at cognitive potentials, or what are called event-related potentials, looking at cognitive function or cortical network activity, not just a response to a sensory stimulus, but more complex processing of that sensory stimulus. And then there's been work that I did looking at functional MRI in these patients. And fMRI in the resting state in patients who are not given a task, we're basically told, the patient is told just sit there. There's not a task associated with the fMRI. There's been a lot of interest in looking at what's called the default mode network, which is sort of the idling function of the brain. It's often the part of the brain that's active during introspection, when patients are just lying there thinking. And introspection is sort of an underpinning of consciousness. And so there's been interest in looking at the default mode network in these patients who are seemingly unconscious but are laying in a scanner getting a functional MRI. So I worked with Thomas Ernst and Linda Chang, my mentors, in the functional MRI lab at Queens Medical Center in Honolulu, and we looked at resting state default mode functional MRI in these patients. And this is what you see typically in fMRI, this kind of triangular pattern of activation of some of the deep cortical and deep gray matter structures of the brain. And what we found is that all these patients were initially comatose after cardiac arrest, but patients who ultimately recovered consciousness and had good outcomes had preservation of that default mode network activity, whereas patients who had poor outcomes really had loss of the default mode network activity. And there was a fairly linear relationship with the amount of network activity within the default mode network and outcomes using the CPC as the outcome measure. So that has been replicated in other groups in another publication, but I think still requires more work before it's going to make it into the guidelines. Okay, and then finally, the timing of prognostication. When is it appropriate to definitively say the patient is not going to wake up? Because patients who kind of fall off that ESICM algorithm, the question is, well, at what point do you stop and say, we've waited long enough and this person even in the absence of negative prognostic indicators, we've waited long enough and the patient has not recovered has not awoken, is not opening their eyes, and is not showing signs of consciousness. And these are helpful data, I think, to guide us as the treating team, and also to guide families of saying, okay, at a week, this data is from patients who awoke, right? All these patients woke up after cardiac arrest in this study. The question was, when did they start showing signs of consciousness in those patients who subsequently woke up? And so if you get to 7 days and the patient has not awoken, there's a 2% chance of subsequently waking up beyond that point if the patient continues to be managed. And I think that's important information for families to have and for the team. And so with that, I'll go ahead and end and say mahalo and see if you have any questions for me. Thanks so much.
Thanks, Matt. Awesome talk. A couple of questions actually that are clinically very relevant to us. One, in terms of the decision of 33 versus 36, I wanted to know what your practice was. So if you've got someone that, let's say, is in status post-cardiac arrest or has global cerebral edema, do you favor more aggressive hypothermia in those patients, or how do you decide?
So I told, as you know, I spent years killing rats and cooling them, and really was very, very convinced that hypothermia was neuroprotective in these patients. And so when the TTM study came out, for about a year, I was in denial. Like, I didn't even want to read it, right? I was just in denial. I couldn't believe that it was negative. I mean, you could argue about whether it's a negative study, but I was very surprised. And yet I wrote the hospital's TTM policy, and I changed it subsequently after that to 36. And I had the sort of, I guess, displeasure of caring for a colleague of mine who had a cardiac arrest. And I had this sort of crisis of conscience where I had to think, okay, this is somebody that I work with and know and care about. Maybe I should cool him a little more, right? But we managed him at 36 degrees, and that really is what we have done. And so I don't really think there's data to guide selecting some patients for more aggressive cooling. I just don't think we're there. There's clinical trials coming out. There's a clinical trial that compares, I think, 32, 34, and 36, or maybe it's even lower. I think it's 31, 33, and 35. There's 3 arms to it. And that might kind of parse it and give us more information. But I think until we do that point, what I have done and what our institution has done is cool everybody at 36 degrees.
The other question I had is a study that compared a MAP goal greater than 65 versus 85 with a hemodynamic augmentation. It was a negative study, but on the flip side, do you think there is potential harm in patients that have lost their ability to, like, auto-regulate, but maybe you need to cap a blood pressure at a certain number because we just let it go? Now, I know initially we don't worry about it because they're typically a little hypotensive on a bunch of meds, but later on, do you say, okay, individualized therapy, or?
Yeah, it's a negative study in that the primary outcome measure, which was cognitive or functional outcome and mortality, were negative, but some of the parameters that they studied, like cerebral blood flow and cerebral oximetry, were elevated in that early goal-directed therapy group where the MAP was augmented to 85. And I'm not sure what to do with that information. I mean, it's not robust information that would make me push everybody to 85, but clearly it had effects on cerebral perfusion and oximetry, and it shouldn't be ignored. I think we need more study there. That's where getting into more, that was all done non-invasively. It was done with
NIRS.
Yeah, I think it was done with NIRS and TCD. It would be interesting to look at invasive monitoring like Stefan showed with multimodality monitoring, and really do some more precision medicine with the parameters that we choose in these patients and see if that has an impact. So it's negative, but I think it's negative, but it generates a lot of interesting hypotheses and data.
Any other questions?
Thank you for the talk.
He's got a question, I think. These guys just want to get in the bar line.
So my question is, now with the TTM trial basically showing that the 36 and 33 are probably equally efficacious, there used to be very strict criteria for people undergoing hypothermia after cardiac arrest, and one of them was that timing issue, like 6 hours from the ROSC. So now that when we get consults on patients who are already like 12 hours or more, and by somehow the decision was not to do hypothermia or even to 36 on them, in your experience, would you still recommend cooling them to 36 at least? And what is the cutoff? Like, is it 24 hours or?
Yeah, absolutely. I mean, and this is a big problem, really, with backing off from 33 to 36. And there are actually studies that show this in a sort of before and after intervention study methodology, is that patients got worse. And they got worse because intensivists got lazy, basically. So, and patients came in spontaneously hypothermic, quote unquote, or already at target. Let's say the patient was 35 when they came into the ER. So we don't have to do anything. They're like already spontaneously at target. And what happens when I go and see that patient like later that day in the evening is they're like 38.5. They're not at target temperature. And so I think the message got out in the wrong way, that the TTM study is negative, quote unquote. Therefore, you don't have to do anything. And a lot of those patients are actually febrile, which we definitely know is harmful. That's clearly harmful to patients. So what I would say is for hospitals like us who changed their institutional guidelines and said, we're going to do 36 degrees, it has to be messaged appropriately that that is active management. Like that is targeted temperature management at 36 degrees. And the patients need this, whatever you did for 33 degrees, they need all that same stuff for 36 degrees, whether that's surface cooling or invasive cooling, and an aggressive anti-shivering regimen. They should be managed the same way. So just, you have to be careful about how that's messaged within your institution.
Another quick question is, like, let's say for the initial CT scan, sometimes you have like maybe some edema on the brain. One of the questions is, should you treat it with hyperosmolar therapy at that time, or you already know that there is an oxic injury and that's why there is swelling, and probably it's going to be futile to use any hyperosmolar therapy?
Yeah, I personally don't. I don't do a lot of osmotic agents in patients who have widespread cytotoxic edema of the brain. I really don't think it's effective. So, if a clinician gave a dose of mannitol to that patient, I wouldn't necessarily fault them for doing it, but I don't personally think that it's effective to do that.
Thank you.
All right, thank you.